We're going to go over another case of closed loop small bowel obstruction, and this is a really good case to review because the findings are a little subtle, and specifically the transition points are not the most obvious or abrupt. So this is a really good example of a case where you want to evoke suspicion for closed loop, even though you don't see the most obvious sharp multiple transition points in the same area. It's a pediatric patient, a little complicated because they have prior surgical history with ostomies in place. But what I wanted to impress upon you is that as you go into the abdomen and into the pelvis, you see a difference in caliber between this decompressed bowel here and then this really distended small bowel there. And things distally, they're kind of decompressed and difficult to appreciate, but you have all this distal bowel that's decompressed, you have all that proximal bowel that's decompressed, so immediately you start to get a sense that this could be a closed loop, and it's definitely a small bowel obstruction. Now, it's a little tough, but these are two areas of gradual transition points here, and I think this is what makes the case really challenging. We'll look on the coronal. You don't see the most obvious sharp transition points, but if you look, there's this huge loop of bowel that comes around, and one of these areas comes together here, and then on the other side you have another transition point here. Again, it's not the sharpest, the most obvious, and if you look at it more and more, you get a sense that there's probably two transition points right here, which is a site of common site of obstruction. So as we look through the coronal, again, I think it's hard for me to point exactly to where the transition point is. I'm pretty sure it's right here, but regardless, we've already reached our threshold because we see an isolated loop of incredibly distended bowel. We know it's a small bowel obstruction, and it seems like both ends of this loop come together somewhere around here and have some kind of a transition point. So this, we can look on the sagittal as well too. Somewhere around here, the bowel seems to have a caliber change, but honestly, it's better seen on the coronal and the axial. So I think it's a really good example where this is a really good threshold. You have this isolated loop, potential to transition points, all this decompressed bowel, proximal, and then some of it distal as well too. And then we see that there is very edematous appearance of the bowel. The enhancement is a little different compared to other areas. And if we look on the axial, I would argue that some of these areas are very indistinct, potentially not enhancing small bowel or heterogeneously enhancing. This wall we can see, this one we can't. Bunch of fluid, inner loop fluid, so this is very suspicious for extensive edema, inflammation, presumed to be ischemic given the mechanism of closed loop. So you want to make the diagnosis of a presumed closed loop small bowel obstruction, and you want to comment on suspicion for bowel compromise. And actually, this case went to the OR. There was a adhesion here that was causing the closed loop, and there was short segment of necrotic bowel with larger ischemic bowel that was resected, and luckily it was only a short segment. The rest of the bowel was able to be reperfused and saved. So this was a great case of closed loop that had ultimately a favorable outcome because the diagnosis was made quickly on call.